Hello everyone, myself Shashank. Now I am going to discuss about pathogenesis of complication of diabetes mellitus. First thing I have to make you clear that when we talk about complications of diabetes mellitus, that pathogenesis, we usually discuss about chronic complications, not about acute complications, because these chronic complications take years to get to form the diseases or complications rather than acute complications which take very short duration. So next, going on to the topics. So what is diabetes mellitus? Diabetes mellitus, it is a group of common metabolic disorders characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. So you can see the prevalence in the world. It's a global disease affecting the world, especially India, high population density. So coming on to the topic, metabolic basis of damage. The morbidity associated with diabetes is primarily due to damage to large and small blood vessels due to the metabolism, which I'm going to discuss further. It includes macrovascular diseases like atherosclerosis, microvascular diseases, compression of retinopathy, nephropathy, and diabetic neuropathy. The unifying theme is persistent hyperglycemia inducing intracellular oxidative stress and metabolic dysregulation. And this persistent hyperglycemia is due to chronic complication. The global burden, as I said, there's epidemiological impact. There's 80% of diabetic mortalities is due to cardiovascular complications, which include atherosclerosis, coronary disease, and the very next complication is renal failure, which diabetes remains the single leading cause of end-stage renal disease globally. Then it comes blindness and amputations, where we can see like diabetic foot ulcer, which is amputated all because of complications of vascular diseases. Next, moving on to the pathways. Key pathways of effective mechanisms. There are usually three pathways which leads to the pathogens of complication for diabetes mellitus. The superoxide mediated inhibition of GPDH blocks glycolysis, shunting upstream intermediates into four catastrophic pathogenic pathways. Usually, this third pathway includes two pathways, PKC, protein kinase C, and exosamine. Both two pathways included in this third part. So, total four pathways are there. The first pathway is polyol pathway, where excess glucose is reduced to sorbitol, consuming NADPH pH and causing severe redox stress and cellular swelling. And this exposes the cell, predisposes the cell to oxidative stress. And sorbitol itself is a cataract to eye. Next, AGE pathways, where non-enzymatic glycation of protein modifies extracellular matrices and activates pro-inflammatory receptors. Then protein kinase exosamine, as I said, there are two pathways. Protein kinase is activated de novo via DAG, while exosamine flux alters nuclear transcription factor functions. Now we are going to discuss about each pathway. First one, AG pathway, that is AG formation. AG is advanced glycosylated end product. This is a non-enzymatic glycosylation. Glucose-derived precursors bind to amino groups of intracellular and extracellular proteins. In serial reaction, glucose plus protein is shift base. We get product AG product. That is advanced glycosylated end products. These H products act on receptor called AGR, that is advanced glycosylated end product receptor. These irreversible AGs accumulate over lifespan of the protein, cross-linking with collagen and other matrix components. You can see the diagram here, electron microscopy. Then RAGE-mediated vascular damage, that's why it's called a receptor of advanced glycosylated end product mediated vascular damage. AGE exert the effects by binding to specific receptors. RAGE found on inflammatory cells, endometrium, and smooth muscles. These AGE usually bind to the specific receptors and cause vascular damage. It includes ROS production, that is reactive oxygen species production, generation of reactive oxygen species causing cell injury. This is one of the pathway. The other includes NFKB activation, where pro-inflammatory gene expression and cytokine release is increased, activated. Then extracellular matrix cross-linking. decreased elasticity of vessels and basement membrane thickening. These pathways contribute to vascular damage. The next pathway is PKC activation, that is protein kinase activation. Intracellular hyperglycemia stimulates the de novo synthesis of diacylglycerol, which activates various isoforms of protein kinase C. These include VEGF production, vascular growth factor production leads to neovascularization, retinopathy. Then AT1 production increases endothelin vasoconstriction. Then TGFP production, which increases deposition of extracellular matrix. This vascular consequence includes PKC activation leads to procoagulant state and increased endothelial permeability, characteristic of diabetic microangiopathy. The third pathway is polyol pathway. In this tissue, like in tissues that do not require insulin for glucose uptake, like lens, nerves, kidneys, excess glucose is funneled into the polyol pathway. That is when in these tissues, like when there is excess of glucose, glucose is taken intracellularly and it is converted into sorbitol by the enzyme auto reductase, which consumes NADPH. I'm going to I will show the next few slides that reaction. Here, sorbitol accumulation increase the consequence of the products which generated in this reaction. The consequences are discussed here. Sorbitol accumulation increases osmotic pressure, drawing water into cells. Cataractogenesis, that is cataract in eyes. NADPH depletion reduces reduced glutathione, makes cells vulnerable to oxidative stress. See, according to this reaction, there's when there's increased glucose, the specific cells like lens, kidney cells, nerves, they take glucose into intracellularly and with the auto reductase enzyme. This auto reductase reduces the glucose to sorbitol. The sorbitol further converted into fructose, but the main thing is NADPH, which is converted to NADP. But this NADP is required for the conversion of for the formation of reduced glutathione, which protects the cell from oxidative stresses. Since NADPH is lost in this reaction, there's deficiency of NADPH, so that the formation of reduced glutathione is reduced. As a result, the cell is more vulnerable to oxidative stress. So you can see oxidative stress is common here, and oxidative damage is seen. And this sorbitol itself is also oxidative damage, and it osmotically it draws water into the cell and causes the cataract of in lenses like eyes. That's one of the major causes of cataract is sorbitol in diabetes. The last and fourth pathway is the hexasamine flux shunting. A fructose 6-phosphate shunt when glycolysis slows due to GAPDH inhibition. Fructose 6-phosphate accumulates in the cytoplasm. It is diverted to hexasamine biosynthetic pathway by the rate-limiting enzyme GFAT, that is glutamine fructose 6-phosphate aminotransferase. Next is UDP glucosamine generation. GFAT converts the fructose 6-phosphate into glucosamine 6-phosphate, which is rapidly metabolized into UDP and acetylglucosamine, a major substrate for protein modification. Next, we discuss about the complication, macrovascular complications, which I discussed in this race. There's like three complications you can see: macrovascular disease, microvascular disease, and diabetic neuropathy due to persistent hyperglycemia. We are going to discuss about these things. Coming to our first topic, macrovascular complications, that is accelerated atherosclerosis and arteriosclerosis. Accelerated atherosclerosis. Diabetes is an independent risk factor for atherosclerosis. The morphology is identical to non-diabetic but occurs earlier, more extensively, and with greater severity. It says that the morphology of atherosclerosis is similar to non-diabetes. Like diabetes and non-diabetes both are similar morphology of atherosclerosis, but do differentiate from both of them. In diabetes patients, atherosclerosis occurs in early stage with more severity and extensivity as compared to non-diabetes. The major causes include dyslipidemia, where very low density lipoprotein and low density lipoprotein (VLDL) LDL elevation is seen. Glycosylation of LDL products impedes its clearance, and endothelial dysfunction and pro-thrombotic stage. These are the risk factors or leading cause of atherosclerosis. As I said in earlier slides, myocardial infarction is the leading cause of death in diabetes. There is in diabetic patients there is 3 times risk compared to general population of atherosclerosis, and this complication of like myocardial infarction or cardiovascular diseases. Yes, when we discuss about peripheral vascular disease, the advanced atherosclerosis of lower extremities is 100 times more common in diabetes. Ischemia combined with neuropathy leads to diabetic gangrene, which I speak in further slides, frequently requiring amputation. Amputations are seen in diabetes because of this diabetic gangrenes. Morphology shows extensive plaque formation in the popliteal and tibial arteries. You can see a gangrene. It's a coagulator necrosis where gangrene dead tissue is seen a bit blackened and line of demarcation can be seen. This is mainly due to atherosclerosis where the vessels are narrow vessels. The vessels will get narrowed due to deposition of fats and endothelial smooth muscle cells, and causes causes the oxygen supply less, or there's a deficiency of oxygen supply. The result is due to ischemia of these regions, gangrene develops. Next, come to hyaline arteriosclerosis. This is the hallmark of vascular lesion. And I repeat this. This is the hallmark of vascular lesion. Amorphous pink hyaline thickening of the wall of arterioles are seen. You can see here amorphous thick pink hyaline thickening of walls. This result of protein leakage across damaged endothelium and increased matrix synthesis. It causes narrowing of the lumen leading to downstream ischemia, particularly in the kidneys. As I said, this arteriosclerosis causes narrowing of lumen and causes ischemia, mainly in kidneys, one of the organs. Next, when we discuss about diabetic microangiopathy and morphology, it's characterized by diffuse thickening of the basement membrane of capillaries in the skin, skeletal muscles, retina, and rena glomeruli. Despite the thickening, these capillaries are leakier than the normal to plasma proteins, experiencing the presence of proteinuria and retina exudates. There is a thickening of glomerular basement membrane. This thickening even more causes protein leakage than the normal plasma protein, normal to plasma proteins. So you can see proteinuria and retinal exudates. When in diabetic nephropathy, the leading cause of end-stage, diabetic nephropathy is the leading cause of end-stage renal disease. It includes 3 lesions like glomerular lesions, renal vascular lesions, and pyelonephritis, including necrotizing papillitis. Now coming to glomerular lesions include further they contains 3 lesions like capillary basement membrane thickening. Sorry, this is a spelling mistake. Is thickening, diffuse mesangial sclerosis, and nodular glomerulosclerosis. These 3 are the basis of glomerular lesions in seen in diabetic nephropathy. Firstly, capillary basement membrane thickening. It's a widespread thickening of the glomerular capillary basement membrane seen in all cases of diabetic nephropathy. It can be detected only by electron microscopy. You can see a thickening of the basement membrane. These capillary basement membranes will become thickened due to the deposition of metabolites. Next, we can see diffuse mesangial sclerosis. It's characterized by diffuse increase in the mesangial matrix. As we know, in glomerular matrix contains mesangial cells. which controls of sodium transport and further mechanisms which I won't go for physiology. There is increased mesenchyme matrix, diffuse increase in mesenchyme matrix in this mesenchyme sclerosis, and the thickening of glomerular basement membranes. This correlates with the declining glomerular filtration rate as the filtration surface area is progressively lost. The filtration is reduced because of this sclerosis, because of thickening of glomerular basement membrane and diffuse increase in mesenchyme matrix. There is no space for filtration, effective space. You can see here in this histology diagram. The next main important lesion is Chemistine-Wilson lesion, also known as nodular glomerulosclerosis. As I see here, nodular glomerulosclerosis, the pathognomic lesion of diabetes, is the main important lesion. Ovoid laminated PAS, PAS, that is Pacific acid gift positive nodules in the periphery of the glomerulus is seen. They contain trapped mesangial cells and lipids. As nodules enlarge, they compress the capillary loops, leading to glomerular obliteration. As you can see, the main lesion glomerular is this nodular glomerulosclerosis, where the nodules due to mesangial cells and lipids trapped accumulates and these nodules eventually enlarge complex capillary loops, leading to glomerular obliteration and further decreasing GFR. Next, coming to the second diabetic nephropathy lesions include renal arteriosclerosis. First, we discuss about glomerular lesions, then renal lesions, which includes renal arteriosclerosis. Diabetes affects both afferent and efferent arterioles. Afferent, commonly seen in hypertension, causes systemic atrophy. Efferent is seen in ID specific for diabetes, causes increased intraglomerular pressure, accelerating sclerosis. Key differentiation is efferent involvement is diagnostic of diabetic nephropathy. Next, complications of medulla, that is as I said before, that includes pyelonephritis, including necrotizing peptitis, a severe form of acute pyelonephritis where the renal papillae undergo ischemic necrosis, much more common in diabetes due to combination of microangiopathy and includes susceptibility to urinary tract infections. This urinary tract infection susceptibility is due to, since there is hyperglycemia, the neutrophils functions are reduced due to high concentration of glucose in the sugar. Since neutrophils is activity of neutrophils is reduced, function of neutrophils is reduced, the susceptibility of the human for the infections like UTI is more common. So we see more infections in diabetes due to decreased function of neutrophils. Clinical risk is it can lead to acute renal failure or sepsis if bilateral. Sloughed papillae can cause urethral obstruction. Next, we move on to the ocular complications, which includes retinopathy, cataracts, and glaucoma. Pathogenesis of retina damage. This includes pericyte loss, where ghost pericytes in capillaries lead to focal weakening. Then microaneurysm, early clinical signs prone to rupture. Then hemorrhages and exudates, results of increased vascular permeability. These three causes lead to the retinal damage. This pathogen is important in terms of retinal injury. It consists of non-proliferative and proliferative. As I said before, it includes retinopathy, cataract, and glaucoma. Cataract, I said, it's because of accumulation of sorbitol, which draws which osmotically draws fluid inside and causes cataract. And glaucoma is due to long-standing diabetes, which is also more common because it increases vascular permeability. This vascular permeability is increased as aqueous humor is increased. So the pressure in the aqueous humor increased and the glaucoma results. Here in retinal injury, we discuss about retinopathy. Retinopathy is of two types: non-proliferative and proliferative. In non-proliferative retinopathy, structural hallmarks is retinal microaneurysms, intraretinal dot and blot hemorrhages, and hard exudates, that is repeat leaks, and cordon wool spots like microinfarcts of the nerve fiber are seen. Pathophysiology is vascular permeability rises, and macular edema develops, causing primary early vision loss. In proliferative retinopathy, structural hallmarks are neovascularization of the retina, disc or iris, that is rubeosis iridis. New vessel lacks structural integrity and bleeds easily. Bleeding is common. Pathophysiology is vitreous humor, fibrous traction, and subsequent reg- hematogenous or tractional retinal detachment. Yes, neovascularization I can see here. It is proliferative retinopathy. Yes, severe ischemia triggers the release of vascular endothelial growth factor, which is required for neovascularization. This leads to new fragile vessels of the optic disc or retina. The retina of optic disc forms a new fragile vessels. This is main important. Fragile vessels which bleeds easily. Complication includes vitreous hemorrhage and tractional retinal detachment. See vitreous hemorrhage due to yes, yeah, to lack of structural integrity, it bleeds easily. It's fragile vessels. Next, we come to diabetic neuropathy. Diabetic neuropathy includes dual pathogenesis, vascular and metabolic. Vascular includes ischemia due to microangiopathy of the vasa nervosum, and this is the vasa nervosum means the blood vessels which supplies blood to the nerves is called vasa nervorum or nervosum. This ischemia due to macroangiopathy of this vessel is one of the causes of neuropathy. Then second is metabolic pathogenesis, which includes polymer pathway accumulation in Schwann cells, leads to osmotic drainage and oxidative stress. As I said, osmotic drainage, the excess of fluid intake, and oxidative stress due to NADPH depletion. Both of these polymer pathway causes in Schwann cell causes damage to it, and metabolically neuropathy occurs. The result is axonal degeneration and segmental demyelination. As this occurs, the nerve transmission is doesn't take place properly, and neuropathy occurs. The clinical patterns of nerve damage include symmetric polyneuropathy, autonomic neuropathy, and mononeuropathy. First, symmetric neuropathy, growth and stalking distribution, sensory loss, precise motor loss. Autonomic neuropathy, gastroparesis, bladder infection, and impotence. Mononeuropathy, it includes sudden onset of cranial nerve palsy, that is cranial nerve 3. Then the diabetic foot ulcer. The diabetic foot means diabetic foot ulcer. In this topic, it's a convergence of three primary pathologies. As we know, like in day-to-day life, in diabetes patients, we see more diabetic foot ulcers or diabetic foot where there will be gangrene. So many of the times, the foot has to be amputated. That is most commonly lower extremities are affected, and those are to be amputated for the better life. The reason includes the three primary pathologies: ischemia, macrovascular disease, and neuropathy. Loss of pain sensation leads to repetitive unnoticed trauma and infection. Poor perfusion, hyperglycemia impairs immune response. As I said, infection is decreased neutrophil activity. And poor perfusion, for there will be more growth for the bacteria. And due to neuropathy, there is a loss of sensation, and there's unnoticed trauma. And as all ischemia, it decreases blood supply and causes cell death. All these three pathologies leads to diabetic foot. The foot ulcers often lead to osteomyelitis and eventually amputation. Conclusion: the complications of diabetes are multifaceted, but all stem from the toxigenic effects of chronic hyperglycemia on the vasculature and cellular metabolism. Early glycemic control remains the only effective way to slow these pathogenic processes. Thank, thank you for listening to my PPT.